So I am presenting on this work that we have been working on, and the co-authors are listed here. Paul was really involved in this work, and we were writing up a paper. So it's really meaningful to me to be able to present this and continue on the work, and something that he was actually had his hands on. Courtney will have a few words afterwards. She's one of the authors, and Marina as well, who are both of them are on the call today. So we were looking at qualitative interviews of merit therapists as well as clinicians who did more standard psychiatric rehabilitation services. So that's what the study's looking at. And of course, I'm going to go into more detail. So, of course, as I'm sure we all know, these psychosocial treatments for people with serious mental illness, psychosis specifically, really contribute to recovery. So all of us do this work, and we know that that's true. More information is needed to understand like why the treatments work, what are the specific elements. And so that's why I really like qualitative research. You get to really hear people's actual words, like what they think. A lot of the research so far has focused on the patient perspective, which obviously we really need. That is so important to just hear what people have to say about the treatments that we deliver with them. And some work has emerged with the clinician point of view. That's important too, because the clinician is one half of the dyad. The clinician is actually delivering this intervention, and they are the person who really has the training and just this different perspective that is also really important. So it's just kind of a different piece of information that we should collect, and just we have less information on it. By the way, I'm happy to answer any interruptions if anyone has any questions, like as I'm going along. I'm cool with that, or I can, of course, address questions at the end. This slide is just summarizing sort of some of the research that has come out with qualitative research, asking clinicians just kind of what it's like to do their work. And so there's been many different things. Therapeutic alliance is obviously one of the things that is really important. It has come up in a lot of research as a common factor that really, really affects treatment and recovery. So that's something that I think has been really well established. But I think the other things that go into treatment that sort of affect it are maybe a little bit less well established, especially from the clinician point of view. So this graphic here is just kind of showing the things that might affect the therapeutic alliance, and then things that might more affect treatment and delivery of treatment. So, for example, clinician optimism about the treatment might affect the therapeutic alliance, or has been shown to actually affect it. So if someone is more optimistic about the treatment they're delivering, of course, that'll improve the relationship with the patient. Some other things are clinician growth. So actually, like how much the clinician perceives their growth in their profession or the actual treatment affects the relationship. Recovery orientation, that one, of course, makes sense. Patient autonomy might all affect this relationship. And then there's these other things that can affect the treatment a little more directly, or treatment delivery. And that's like how flexible the clinician is. The emotional processing of the patient can affect like this view of how effective the treatment is. And the treatment orientation can affect things just kind of like how the clinician can perceive their work. So those are just kind of some of the things that have been found so far, although like I said, some of this research is kind of a little earlier. We just need some more information about it. So we wanted to look at clinicians who deliver merit and clinicians who deliver like other sorts of psychiatric rehabilitation programs, just to kind of see what people say about their work with individuals with serious mental illness. So really, primarily, we just wanted to kind of broadly explore the experience of clinicians working with serious mental illness and psychosis. And then a little more specifically, we're looking at the similarities and differences between people who identify as merit therapists versus clinicians who do more standard or broader psychiatric rehabilitation programs, and I'll get into more of those details soon. And merit, I think, is really just a great treatment to be able to look at the clinician perspective, because as we know, merit is a very active treatment. It's very intersubjective. So we really work with the patients, very collaborative. So it's just really important for us to, I think, get the clinician point of view in this sense. So we had a sample of 20 clinicians total. 10 were merit therapists and 10 were people who delivered more standard psych rehab programs. And so everybody was master's level or higher. The majority had some kind of background in either psychology or social work. Some of the programs for individuals who did the psych rehab programs were in some housing programs, did some more general case management, or did substance abuse programming. So it kind of varied a little bit, but they were involved in those sorts of things. And we collected the data from 2 different hospitals here in Indianapolis. So the primary measure was a semi-structured interview to really ask about the recovery process with these different interventions, any changes that happened in the perspective of the clinicians through their work, and then just kind of personal experiences as it relates to rehabilitation. So sorry for the wordy slide, but just wanted to show you the actual questions. There were 18 questions. So it kind of touched on what is your approach or method? What things actually affect recovery? What's most gratifying in your work? What kind of things are surprising in the work? Anything that has really changed? What does discharge look like? So those are some of the sort of general things that we asked. So the analysis was using thematic analysis. Those that are not familiar with this, you basically go through these multiple phases of coding where you look for patterns in the data. So the first round will be just reading over the interviews and getting used to kind of what is the content, and start to maybe form ideas in your mind about the patterns that might be emerging, which will eventually be themes. Then as it progresses, you have these coding meetings where you want to pick out agreement or discrepancies amongst the different patterns. So for this particular paper, we had 2 coders, which were me and Courtney. And so we talked a lot about the data and sort of what patterns we were seeing, what do we agree on, what are some discrepancies that need to be solved. And so it's kind of to check each other and to make it more valid, but that's kind of how it works. So you go through and you identify these codes where you're looking at the content, and then you're looking at patterns across the different data. So you're looking at saliency and frequency across those. And for this particular project, we were looking on just kind of what are the experiences of therapists, what thoughts do they have about their work, about recovery, about those sorts of things, and tied to the questions that are being asked in the interviews. And it was done separately with the 2 groups. So merit therapists were one group, and what are the patterns across? And then the standard psych rehab was a separate group. What are the patterns in this group? So I will go through these themes in more detail, but here they are. There were 7 different themes for merit therapists, and I'm just going to go through each one. So I made these little images of just kind of some of the words that were used This is not necessarily how we do coding, but I thought it maybe gave like a good depiction of what kind of, what are the general, how to summarize this, like each theme. So I think the comfort with uncertainty, it was this sort of like openness where the therapists were giving space for what naturally emerges in the session. So it was really this third bullet point here, like therapy is an organic process of really understanding like this evolution of someone's life and allowing like whatever is happening to just emerge naturally. As we know, Merit doesn't really have like a very strict structure to every session. We sit down and we talk with the patient and we decide together what we're going to talk about. Some of this comfort with uncertainty involved being able to tolerate discomfort in the session. So that was sort of allowing this space for anything to emerge. It might be pain, it might be something that the therapist just didn't expect from the session, which can just be uncomfortable. It might be tolerating any perceived discomfort the patient is having, allowing that to exist and reflecting on that. So it was this organic process. You don't know what will happen in the session and being comfortable with that. Next was this emphasis on collaboration, which of course is a main part of Merit. And so this involved thinking together about someone's life and really a non-hierarchical relationship. Again, like sitting down with the person and having a conversation. It's this this partnership with the person that is very like mutual, non-directive, that you're figuring these things out together. Next theme is being part of therapeutic change. So this one was where the therapist described some of these things that they're seeing the patient change, this progress that's being made in therapy. I would say the majority of the therapists talked about these big changes in thinking, which of course like might be these metacognitive changes, thinking about someone's life, cognitive processes. This was something that was really powerful for therapists just to kind of see these big changes in someone. Maybe someone wasn't able to have really any thoughts in their mind and it was just completely blank. But through the course of therapy, they could say that their thoughts were more full or they actually can identify these different thoughts. And then many therapists also described like these changes of functioning that actually happened afterwards. Maybe people were improving their relationship with others because they could reflect on themselves, reflect on others. Maybe people were going out in the world and getting jobs, things like that. So it was these thought processes or this metacognitive growth that eventually went into functioning for many of the patients. So this one is different from being able to collaborate with someone. Collaboration was more like having this back and forth, be able to think together with someone. Connecting with clients, this theme was more like talking about the relationship, this deep connection that you have with patients. And the therapists were sometimes like surprised by this, of like how deep this relationship went. And much of it, of course, is long-term work. So you're sitting with someone an hour every week, maybe for years, and you're able to have this rich relationship with someone and really go in deep talking about their life and having this like very real connection with somebody. It's not just a therapist and a patient sitting, it's like two humans sitting in a room and really getting to know each other. There was this emphasis on patient autonomy that really came up a lot. And it was this emphasis on self-direction in the therapy room and making sure that people are talking about what they want to talk about and creating these like more meaningful goals because they actually they actually are relevant to what the person wants to do. It's not the therapist deciding what the patient wants to do. It's us working together, figuring this out, and the therapist asking the patient, like, what do you want to do? What do you want to work on? Like, what do you want from your life? This one was a really prominent theme, and that was the therapist talking about experiencing some sort of growth. There were 3 different sub-themes in this one, so there was a lot of content there. The first sub-theme was therapist growth, meaning more like professional growth of them being a better therapist, kind of feeling more confident and knowing what to say and be able to grow in that sense of these different areas related to professional growth. The second sub-theme was personal growth. So this one was more related to just like as a person. I look at humanity in a whole different way. I am so humbled to like be sitting with this human. I really like my relationships in my personal life are different as a result of therapy. This was something where people just say they're just transformed by therapy and being a merit therapist outside of the therapy room. And then the third sub-theme is the shift in recovery mindset. So I suppose that one was more professional too, but it was directly tied to recovery mindset of being more, I guess, more subjective, more individualized. Like recovery can mean something very different for each person. And it can mean a lot of things. It can mean a change of thinking. It can mean what the person wants to do with their life, relationships. It was kind of shifted from their mindset before, and they were able to grow in like many different ways. Okay, this is the last theme. So the therapist use of self-awareness. So they really used themselves and used their thoughts and themselves as like a tool in a therapy process, and it was very active. So the word scaffolding was used a lot, and many of us use this, of course, where we use our own thoughts to scaffold the patient's thoughts. Therapists talked about using their own reaction, so kind of thinking about in their own mind what this interaction is like, and then sharing their thoughts with the patient. And so constantly sort of this in the moment process of being able to use themselves in the room and outside the room. They also talked about like thinking about the therapy interaction outside of therapy and then bringing it back to therapy. So just very reflective process on the part of the therapist is to make sure that they were active in the therapy room and kind of bringing what they could as a therapist themselves. So the other clinicians had 4 themes, but several of these have sub-themes. So it's kind of just organized in a different way. So I'm going to go through these as well. There were several differences between the 2 groups. This was one that was very different, that the psych rehab clinicians very much valued a structured approach. They focused very much on the treatment plan goals. So I think many of the programs like are time limited, and so they have to get these things accomplished in a certain time. So they have these very structured goals where someone needs to get a job, they need to use substances less, or things like that are very behavioral, which is sub-theme 2, that they had a behavioral orientation. So specifically, a lot of people mention motivational interviewing, cognitive behavioral therapy. They really valued those sort of approaches in their work. And as a result, the roles were very straightforward. And so they were the person helping with housing, the person who is going to be your case manager, They mentioned like from the outset, they talked to the patient about these very like specific things that they are going to do, working on these like very tangible goals with a person. Many people talked about this like strengths-based approach where they used a lot of positive reinforcement. It was very client-centered. So it was a very kind of like positive interaction using person's strengths, going back to the client, like, what are your strengths? How can I help you with this and achieve your different goals? This one was a little bit similar to the merit therapist, but again, different in terms of like behavioral change. So the clinicians really valued, of course, progress. I mean, this is why we do this work, I think, is to see people improve. But it was more behavioral. It was not really as much like thought processes, but like seeing people do specific things. So could be increased attendance, could be getting a job, improving symptoms, things like that. That was a very important part of the work, of course. But it was a little bit different type of progress. Building rapport was, of course, important. This is the last and fourth theme. And the sub-themes for this one was to create a supportive environment and to prioritize comfort, like making someone really comfortable in the therapy room, and feeling like okay to trust me as your clinician. And it was this like supportive environment, again, like very positive kind of relationship and atmosphere. Okay. So I think in terms of, to summarize these results, merit is a very active interpersonal therapy, as we know. So I think a lot of these results kind of make sense in that realm. So they really align with our elements and assumptions of merit. I think some of the specific ones were like this collaboration, the therapeutic relationship, using yourself as a tool, so this self-awareness and patient autonomy, like that really lines up with what we say we're going to do. So I think that is obviously a good thing. That's what the therapists are reporting and the things that stick out to them. I think some of the similarities between what we do and kind of more standard psych rehab is the therapeutic alliance. We all want to have some kind of good relationship with our patients. We all value progress, like we want to see people improve. And we all value just like quality interventions. We want some kind of evidence-based approach of what we're actually doing. Some of the differences is that the psych rehab was more focused on like these specific behavioral goals and more clear like boundaries with people. Like, this is my role. And like I said earlier, I think it's just very time limited. And so you have these really specific outcomes that you have to achieve. Some of the things that were sort of more unexpected and just kind of got me thinking more about merit and what is it that we actually do. Discomfort with uncertainty was really something that I found just really interesting about the findings and unexpected, like I said, but also makes sense as I think about my work. Like, therapy can just be really uncomfortable and painful, but pain is really part of life. And so in the therapy room, we kind of just let things happen as they are. And it, I think, is a really powerful process. And I think it is an important part of merit, is just being comfortable with things being uncertain, like not having a clear agenda or a specific agenda when we go into therapy, but that's okay. And then the growth part was a very salient theme that I just didn't expect, I guess, especially the part that was the personal growth. Like I have listed here, I mean, merit is just very immersive, really personal and transformative. I don't know. I don't think that's an overstatement, at least for me in my work. Like, I think that it really is. And we get to know people for a long time in many cases. We really are, I think, walking with patients in their recovery and really going in on a different level. sitting with patients and connecting in this like real way. And I think I was thinking about what is sitting with someone mean, and I think really accepting them for who they are and allowing them to be themselves, and that really can create a lot of reflection for people, and just really being able to live the life that they want to live. And I think that is very different than some other forms of therapy. And some of us have the freedom to not be as time limited, so we can kind of explore the kinds of things that people want to explore. And so I think that's what subjective recovery is really about, and having this like real non-hierarchical relationship with people. Okay, so this is the last slide of just some things that we're thinking about in the future. Of course, more qualitative research. I love qualitative research, and we are actually working on a study of looking at burnout and asking people some of these questions that we asked in this study, and going a step further to see if merit is specifically affecting burnout and how. And then just kind of more implementation research related to merit. I think some of these things we found in this study can have implications for implementation, and kind of how do we look at merit as a sustainable treatment and something that therapists really want to do. And I think it does prevent burnout. I think it's something that people really enjoy, and we really get to know our patients, and have this real relationship, like I said. So those are some of the things that I was thinking about as we're doing this study, and as we think about like what are the steps that we take next. So I'm going to stop sharing, and Courtney may have some thoughts, and I am very open to any thoughts anyone has. This is a study that we are getting closer to submitting and writing up our final product for review. So there's some space for feedback on that realm as well. Thank you, everybody.
Yeah, I guess before I share my thoughts, I'm curious if anyone had any initial like reactions or anything that they wanted to share before I jump in.
I had a few initial reactions. I think one thing in particular that really, it's a great study. I love the qualitative work. You learn so much. But I think one thing that just really struck me was the stark difference. And when we talk about implementation and dissemination, I think it helps to kind of put words to my experience of collaborating with other providers and trying to explain what I do. And maybe, if anything, it gave some ideas about the gap between the two groups and how to communicate differently when working with case managers, for example. Yeah, so I just really appreciated the different words and like summarizing those and thinking again how different it really is, and how to start talking to other providers in a way that makes more sense. So thank you. I appreciate that.
Yeah, I think one of the things that I was going to share that was kind of related to that was just like reading through these interviews and seeing how differently the groups talked about people. I find I've been doing this for 3-4 years now, and like mostly only this. So I feel very like kind of insulated in this little merit bubble. And I honestly sometimes forget that people, non-merit therapists or people engaging in these different types of work, think about people so much differently than I think the people I've surrounded myself with think about people. So there were just huge differences in language used. And I guess we can't assume that just because we use different language and we think about things differently, we can't assume that we're really doing things differently. But I'm inclined to say that we are doing things a lot differently than some other groups. So yeah, I agree that this new language, or this language, can also be really helpful in interacting with non-merit therapists and maybe the people who are doing things a little bit differently. So yeah, that's an interesting thought. Any other initial reactions? Okay, yeah, so I guess I'll share some of my thoughts, and maybe that will spark some conversation. And of course, we'll have time for questions and additional thoughts at the end. I think that the interesting part for me here was looking at the differences between the groups. So of course, like, there's going to be some commonalities between people doing work with folks with SMI, but the differences felt really big to me. And I think the one that felt the most different was this idea of therapeutic alliance. So there's been so much research on like how important the therapeutic alliance is, and how like maybe that's what doing everything in therapy and all those good things. But I was struck by the fact that in the merit group, it was really this bigger thing. It was about really connecting with people and trying to understand them and really collaborating with them. And in the control group, it was more about kind of like providing a safe space and making people feel comfortable, which all have their place and all can be good things. But I guess when I think about my work with people and as I try to develop rapport, I guess my first priority is never like making sure this person feels comfortable and making sure that they have like this nice safe space where they'll never be challenged, and I'll only, say positive things to them and all that stuff. So that's one thing that really struck out to me. And then the other thing that stuck out was this growth. So there wasn't really a corresponding theme in the control group, but I think that's because they didn't necessarily talk about growth a ton. And I do want to acknowledge that the merit group was a group of younger therapists, kind of still in training and still developing their approach and how they're going to think about people. So I think some of that growth talk was related to just kind of still being in training and figuring things out. But I think it's something bigger than that too. And maybe that can be a question that we try to answer down the line. But one of the things that really shocked me was that members of the control group, there was a question, I think, and the question was something like, like, what has surprised you about your work? And so many of these people in the control group were like, oh, nothing. Like, I'm not really surprised anymore. Like, working with these people doesn't surprise me. I kind of know what to expect. And I think almost every merit therapist was like, I am constantly surprised every single day. Like, someone says something, I do something, and it's surprising to me. So I don't know what's driving that, but that's something that really kind of stuck out to me, was that merit therapists seem to be just like really open and willing to still be surprised and maybe not be the experts in the room all the time. So I guess those are some of my follow-up thoughts and reactions. Does anyone have anything to add about kind of what I said, or something completely different?
I was just gonna say, like, I really liked that question, like, what surprises you about the work? Because like you're saying, there were very different responses to that. And I think related to that, I think might be like that openness to expect the unexpected, and then the unexpected happens, like allowing for this to happen, and constantly being surprised and being open to this like natural process of allowing what's going to emerge.
One of the things that stood out to me, and thank you guys both for presenting that, was really interesting work and like interesting to see it kind of mapped out in that way. One of the thoughts that kept kind of like cropping up in my head is, I wonder how these two groups, I don't think you had a question on this, but maybe I missed it, how they like deal with like failure in some way, like especially the control group that has like such behavioral tasks. I wonder like what it's like for those therapists when the person doesn't get housing, doesn't get a job, doesn't like do the task that they're sort of like working on. Because I think that's something we see all the time in therapy, is that like people have some kind of goal, but like things get in the way, things get messy. we're not, our position is different, that we're not trying to get someone to do a certain thing. We're trying to think with them about what they want and understand what might be barriers, but we're not really like trying to, create a specific outcome. And I wonder how that might like contribute to things like burnout and just like how people think about their role. So I didn't see a question about that. Did I miss that?
There is a question. It's maybe not directly to it, but what are the biggest barriers you encounter with regard to patient-client recovery? And those were fairly different between groups. Like I think some people mentioned like some of the systematic problems, many related to the VA. I think some people mentioned like resistance, which I'm remembering more from like the control group. Courtney, I don't know if you have memory of like the other things. I think less of the themes like actually came from that question because they varied like even more.
I think one of my memories, at least, is in the control group, a lot of times like specific symptoms were listed as a barrier, or like working with a specific type of person was kind of seen as a barrier. So that's something that stuck with me. And then maybe one other question that kind of got at what you're saying, Bethany. It was a question that was basically like, how do you know when the work is finished? Like, how do you know when it's like we're wrapping up and like the people or the person you're working with is like where they need to be? And I remember pretty clearly in the control group, almost everyone I think was like, oh, like, well, when the treatment goals are complete, therapy is complete, which is fine. Like that's makes sense in a lot of settings, I think. But I think the merit group was really more focused on it being a joint decision and really thinking about like, well, if I was thinking that we weren't making progress or things were wrapping up, like it would really start with a conversation with the patient, which I think makes good sense here. So that could be kind of related to what you're saying, but maybe not exactly. I also really like the burnout piece of this. I remember at the end of internship, I was doing my mental health rotation and I was feeling awful. I was exhausted, like I did not want to do it anymore. And I remember complaining to Paul, and he was like, well, if you're not being honest with your patients, like, of course you're going to feel burnt out. Like that's a big like burden for you to try to carry, is if you're not really trying to connect with them and you're just doing this this structured approach and like you feel like you can't really tell them your thought, like of course you're not going to enjoy the work. So that's something that really stuck with me personally as well on the burnout piece.
I was going to add that, Courtney, that's the part that I think is most interesting to me. I think the between group comparisons, I think it's all fascinating, but I think that makes sense because psych rehab providers, I work with them all the time, and some of these research studies I do, they're under tremendous pressure to like get people jobs and get people housing and keep those things, and they're not psychotherapists. And so I think that's an important distinction to think about when we think about what some of their responses are. And this study that I'm doing, that Laura and Courtney are both a part of, so we've done consultation with these psych rehab providers, they're voc rehab counselors who are facilitating these groups that we have. And so I've actually introduced the metacognitive model and thinking about what that is. And we've worked on helping them conceptualize patients or veterans that way. And I do actually think it's helped because I think some of the things that I've observed are consistent with these findings, that they feel like, for example, if people are struggling, that's because they have a lot of symptoms or because they just need more support, when maybe actually what it is they want you to tell them that they don't have to try to find a job anymore or they're too sick to work. That's just an example. So I think it's a little apples to oranges. I mean, I think this is an incredibly important qualitative study. When we think about these findings, I mean, yeah, of course they said that it's the treatment plan, because once they find the housing, then they move on to the next phase of the services or whatever it is. And if they don't, then the provider gets dinged on, having not followed the fidelity scale or some kind of SAIL metric or something that we don't do in merit and things like this. And then, as you said, it leads to all this burnout for obvious reasons. So those are some of the things. But I think understanding how merit therapists experience this work, that to me is, when we've asked those questions before, but I think I like how you presented it too, Laura, with these like word clouds. I was really fascinated by that. But I think we've added to it with this study and sort of understanding a little bit more nuance about this work. And we asked different questions this time too. So congratulations on such a wonderful study and presentation here.
Yeah, I also think that I know at the VA, at least in the PRRC, there's a certain luxury that not all settings have of being able to do longer term work and not having as much pushback against the system, right? Because that clinic at the VA has been doing that approach for so long that I can imagine it's much more difficult in different settings with different goals. Just have to constantly like push back against that pressure of the system and the pressure of time limited therapy and the pressure of, like really goal oriented stuff. So I don't want to forget about that either.
One thought that I had, Laura, I know at the beginning of your remarks, you mentioned that there was a little bit of previous literature that approached therapy in this way, but not a ton. And I found myself thinking, I wonder if there has been any work with psychotherapists' experience outside of public mental health or serious mental illness contexts, and how much some of the things that are being said here are similar to other long-term kind of depth approaches. So I don't know if that exists, but I guess it just had me thinking like how much of this is just a sort of something that's novel within this context where these systems really favor behavioral change and also just kind of entrenched stigmatizing ideas about people with serious mental illness and not being attentive to their interiority or positioning ourselves as equals rather than benevolent experts. So I wonder if there was, people working from a psychodynamic or interpersonal approach, long-term work with people who are not as marginalized, if some of the similar themes would show up. And what Merit is somewhat doing is kind of bringing that type of psychotherapy tradition into a setting that has lost sight of that. I don't know.
I remember there being some qualitative studies on more psychodynamically oriented therapists. I don't remember the details of that. I think some themes related to growth sort of came up in like a slightly different way. But I don't know that there's been much of it. Courtney, I don't know if you remember any details, but I remember there was some psychodynamic, and that was the part I remember about like longer term therapists, but I don't remember the setting of those.
I do not recall. I have no idea. I would guess that a lot of these things are not completely unique to a Merit approach. I think the stigma piece is interesting. There was like some talk of including like rejecting stigma as a theme in the Merit group. I think that might have been like filtered in a theme differently, but the idea that people are doing these types of things and this type of work, but maybe not in an SMI approach due to like this wider stigma facing folks with SMI, and thinking that they don't improve with therapy, right? Like therapy is not useful for them. So that's an interesting thought. But I don't remember exactly about other literature that kind of focused on this stuff.
Something that has occurred to me that I was curious to hear if y'all would elaborate on is the earlier in this meeting, we talked about, kind of dissemination and promotion of this work. And I was wondering if we talked about this a little bit in the context of burnout from the control group. And I'm wondering if there are things that became evident to you. And Marina, you kind of alluded to this too in some of your work of introducing merit for folks in kind of more conventional psychosocial rehab settings who are with their particular areas of difficulty. So I'm wondering to hear from y'all as you dug deeper into the transcripts, if there were things that occurred to you as, this is sort of a dissemination hook for merit, that if this is a particular struggle that the folks who are not practicing merit are up against, and it seems like merit would address that especially well. It kind of like putting on that hat from the dissemination side, kind of what you would speak to with that, since you've been in depth with those transcripts. I'd be curious to hear. And again, I think the burnout piece starts to speak to that. Although there are other, institutional pressures that lead to that burnout too. But so anyway, just curious to hear how you all would think about that application of this work.
One of the things that comes to mind is one of the questions we asked on the interview is like, what is, maybe it wasn't directly asked, but something about being rewarding, like what about the work is rewarding to you? And I think between or across groups, one big difference that I remember seeing is kind of like in which it's rewarding is really different. I think for merit therapists, it's like this rich relationship, like being able to see the process of people change and being able to sit with someone and just kind of be two humans, like talking and figuring things out. And I think for the other clinicians, it was more kind of tied to like these specific behavioral goals, like that part is rewarding. And so I think both groups like were rewarded by seeing people grow and change, but it goes like beyond that into like a few of these more different things. So I think merit being like a really enriching type of approach, I think is kind of a hook. I think that's something like to present it as something that really is rewarding and you feel enriched and you feel like you're growing like as a clinician and as a person. So that was one thing that came to my mind.
Yeah, I think the burnout piece probably has the most like bargaining power, for lack of a better way to put it, and that if you talk about how people can, or organizations, right, can help their therapists prevent burnout and retain therapists for longer and like do all those economic pieces, I guess. I think that has a lot of power in these big systems. But so I really think like that's the piece to push forward if we can figure out that like merit helps therapists not hit burnout so quickly or not as much. I guess for me personally, this idea of like being with someone in the room, that feels important to me personally. I've been reading about Soterra houses from back in the 70s and how like the core piece there was just like being with someone, like being in the room, like connecting with them, like this interpersonal thing happening. So I don't know. I mean, my hope would be that there would be like a resurgence of that eventually, like maybe as the behavioral piece dies out a little bit, as like psychology just swings back and forth between those like kind of big ideas. I would imagine that merit's focused on really just being with people would play an important role down the line, and also feels like a piece that is abstract and hard to define and like hard to think about, but it seems like something that anybody could do, right? If you're even focused on like finding housing for this person, like you can still be with them in the room. And I don't have a definition for what like being with someone really means, but I think everyone here at least like kind of knows. So I guess that's like my practical answer, and then my like personal hope for the field.
Yeah, it seems also as occurring to me that thinking in terms of the mass might also kind of help people understand when something's not working in these like very concretely defined outcomes. This isn't, it's just not happening. And they feel like they're banging their heads against a wall. It's like, well, let me think about, like, see the zeros and ones, you know, of the matrix here, you know, like see that what's actually going on behind the scenes, that's actually going on inside the person, as opposed to these kind of external markers. I wonder if that might be experienced as a relief to people, and like, okay, I can kind of see this differently, and it helps me understand why things are going the way they are. But again, it is kind of hard. It's a difficult, early on, I think it's hard for folks to wrap their heads around.
Yeah,
Yeah.
definitely.
Sorry, Courtney, I was just going to add to what Ben was saying. I mean, I think with these voc rehab counselors I've worked with, this is what happens. They'll be like, this person's come to my office 10 times a week for the past 6 months and hasn't made one step towards employment. And that's what we're supposed to be working on. I have no idea what to do. He says he wants a job. I have no idea why he's behaving this way. And so then, like, we sit down and think about it through sort of a metacognitive or merit case conceptualization, just broadly speaking, thinking about the person's agenda and what's really going on with them. And then I think it is a relief to have a different understanding through that way, and then think about, like, okay, if this is the case conceptualization, then what might the response be to this individual, or how can I change things up? I think that's the main way, like, we've used it. We also have, it's a CBT for a work group, and so we've used it there. We have narrative exercises and thinking about, like, what reflections might be appropriate for people in the group, and going through case conceptualizations for each person using this framework. Aside from that, I've been trying to think about other ways to adapt this for the areas of psych rehab, and I'm interested, I do work in employment, and so thinking about, like, how in other ways this may make sense. Like, everyone's saying, how do you sit with the person and voc rehab when you're supposed to get them a job, and, you know, figure out what's going on. So these are some other, like, things I'm very interested in thinking more about and figuring out.
Kind of like, this is a wonderful presentation. Maria and I was kind of resonating to your point that there's times working with other professionals, their goals are literally different than ours. You know what I'm expected, if I'm a voc rehab person, I'm expected to achieve certain goals, which is very different from sitting with someone. That's probably a way to bridge those things together. But I think part of the challenge is that different professionals literally have different goals and different things. They view their mission as what they need to accomplish with the client.
I wonder too if another selling point is related to the theme you highlighted of tolerating uncertainty. Because when I speak with non-merit therapists who work with SMI populations, the sense I get is they'll have a consultation group and someone will say, I don't know what to do with this person. I feel really confused. And that's kind of like a dead end. And then the solution to that is to just throw a bunch of different services at them. And there's no conversation about the confusion or what that might mean or what it might be like to connect with the person or share your confusion with them. And I think, like, merit has a very different approach to that feeling of confusion and don't see that as like a barrier to effective therapy. So that might also be another way to just even make help therapists feel more comfortable being uncomfortable. Could also be a relief, as someone said earlier.
I like that, Sarah, and it's kind of related to, like, burnout in a sense of, like, in merit, we can be authentic with people, like, we can talk about that confusion. It's not just sort of like bubbling up inside and maybe creating burnout down the line.
Yeah, I think just circling back to the MAST A really quickly, a lot of us were in merit training with some new students last week. And I think one of the things I think Bethany brought up was, like, if you're trying to do CBTP with people experiencing psychosis and none of your interventions are landing, like, perhaps they're just not there metacognitively yet. So I feel like that gap, right, where, like, some of these interventions we have don't work with some of these people, maybe, like, that is a gap between S0 and S4 or 5, right? Like, that's where merit can, like, really be sold. Yeah, that's just a random thought, but Any other thoughts or questions that people are having?
I don't know if this is like a new thought, because I feel like I keep hearing this theme like throughout our conversation today, but somewhere my mind keeps going is like really thinking about how merit is an approach that like centers on dialogue. You know, like we talked about this idea of like relating to the person, sitting with the person. And Courtney, you were mentioning like different approaches where like the whole point is just to like be with someone. And I think for some people, when I'm teaching them merit, it's like that idea is like a relief in a lot of ways. Like you're not here to fix the problem for the person. You're not here to tell them what to do or like solve this like massive amount of marginalization that they faced in their life, or you know, these different challenges, but you're there to like think with them about things and to partner with them and to like share your thoughts as an authentic person. And I think for some people that's such a relief. Like that's like, oh, okay, I don't have to know what to do. I can just sit and I can be confused, kind of like Sarah was saying. But I think for other people that's like absolutely terrifying. It's like, well, there's not an answer. Like I don't have an intervention I can fall back on. And so I wonder a little bit about like, you know, it's always hard to tell who's going to take well to this approach and who won't. I think sometimes we think folks are like really well suited for it and then it just doesn't work, or vice versa. But I think that like that idea keeps coming to my mind and thinking about like the stances in the paper that Jay wrote a couple years back, talking about like stances that impede dialogue. And this idea of like the minister of comfort is one of those. And I kept thinking about that when you guys were presenting like the findings for the treatment as usual group, that it sounds like that's a lot of what's happening is like those folks are comforting the people that come in. But that in some way that perhaps is impeding their ability to have like an actual dialogue with them, to like have conversations about what they really want, or you know, if they don't really want housing, or they don't really want to work, or they don't want these kind of concrete goals. Like it just seems like it leaves you sort of stuck. So I don't know, those are lots of thoughts, I think, on one theme of just like trying to think about how one of the core things, it seems like what's happening here is that this is like a dialogue that is transformative, not just for the patient, but for the therapist. And that seems like a deeply rewarding and rich experience for folks, but maybe not for everyone.
I also sort of sparked this thought, and this I think has kind of been said for the last few, but I was talking to this guy, one of the group, the members of the Australian consultation group, and he was describing having gone out on like a home visit as like a first meeting with someone new. And the person was really uncomfortable with, you know, obviously got kind of worked up by having someone in their space in the home, and was saying a bunch of strange things, and it was really hard to follow. And his comment was that had he not been introduced to the concepts of merit, he probably would have just nervously wrapped the session up like immediately and left, and like felt like he was bothering the person. But instead he kind of hung in there and was patient, and they eventually got around to like kind of sorting through some of the disorganization and the person's, you know, initial discomfort with him, and we're able to kind of get things started. And so I think that probably speaks to this idea of like tolerating uncertainty, but I also wonder, in compared to like the folk rehab folks or whomever, if it also allows things to start and happen that would just be shut off immediately in the other approaches, you know. The throw a bunch of services at them, I think probably is the usual response, but then whether any of those services land, because we haven't actually like spent time forming some kind of connection that the person might be able to use those services. So yeah, like I said, I think others have kind of commented on that same thing, and it does seem to get maybe both to the tolerating uncertainty, but also just recognizing the potential for psychosis to be understandable, and the importance of not fleeing right away.
Yeah, I guess one thought I'm having is I'm sure there's not an answer to this, but I'm curious how much we can teach someone to be comfortable with uncertainty? Like, is it kind of just like part of your personality and like you can do it or you can't do it? Which I'm sure it falls in between these somewhere. Or over time, as you do it more, does it just get easier? Yeah, I'm thinking of a close friend who did a practicum at the VA, and she hated uncertainty to the point that she sent me a paper that I found in my email about the doubt certainty continuum and how she was not made to do merit because she could not tolerate this level of uncertainty. So it's so interesting when like these small things that you've had in like one-on-one personal conversations come up in the research you're trying to do as well. So yeah, and I'm sure, like I said, it's a little bit of both. Like as you do it more, you just get more comfortable with uncertainty and maybe like not always knowing what's going on in session. So yeah, I guess for the newer folks here, sticking with it.
That's a good point, Courtney. I think maybe that's like one reason people gravitate towards like certain interventions over others. And I think there's a lot of benefits to merit, but I think also like some of the things need to be unlearned, or like some of it can be taught. I remember like when I first was even doing therapy before I learned merit, I felt so much pressure to like, I don't know, fix the person or have the answers or like be the clinician with this expert knowledge. And I think that was part of like my anxious personality, but I think unlearning it gave me a lot of like freedom and like less sense of burnout. So I think because I really like merit and saw these other benefits to it, I could sort of like train myself to be like okay with uncertainty and not have the answers and all those sorts of things. So I guess it depends.
Laura, do you have a timeline on the next study, like interviewing people and like the burnout piece you were mentioning?
Yeah, it's a good question. We are currently working on like the protocol and everything to submit to IRB like really soon. So we're hoping to like actually do the interviews before the end of the year for sure. And then of course write-ups after that. So I'm really excited about this study. I think it'll sort of like build on our results from what we presented today, and just think more about these specific things, namely burnout and sustainability and stuff like that. That's even more related to implementation.
Just mentioning that about implementation, that I'm not sure exactly where we're going with this line of research and what the plan is, but that'd be fascinating or potentially very useful to share this with other professionals. So it's not just sort of like an in-house sort of thing about how we survive in this evil environment. I'm exaggerating, but how can we help our colleagues, right? You know, how can this be something we join together with the people we work with every day? And maybe there's something useful for them as well, even though they may not be particularly interested in merit, but what can we share that will help them in help them in their professional lives?
I do not have a plan for the implementation research, but I just sort of get excited about it in my mind. But I think that is one thing that could be really helpful for all kinds of people, because like I think in general there's just a big gap between these evidence-based programs and who's actually using them. So that's another line of research I really love, is just implementation research. So I think as we get more involved with like clinical training and doing these more formal things, we can kind of collect some observational data and publish some more research related to implementation that will help us, I think, grow merit, but also help other professionals who are just looking to implement their different evidence-based practices.
Yeah, I think maybe just one follow-up thought is that obviously not everyone who's trained with Paul or at Eskenazi, like not everyone sticks around and like continues just doing like by the book merit. Like people go on to different settings and do different things and focus on all kinds of different things and still managed to find a way to incorporate like part of merit or like whatever they found was really helpful about merit into their work in these different systems that presumably like don't know much about merit and have been really successful doing that. So I think there's something to be said about like taking what works and keeping that moving forward.
Yeah, I just had a very similar thought. Like I'm curious like how many of these maybe the merit principles or elements are kind of transferable, because I'm starting in a setting now where it's difficult to, you know, deliver merit to fidelity, but it feels like you take a lot of the merit like stance and you can use that. And I'd be curious to see like maybe that's something that can also translate to people who are in a setting that doesn't allow, you know, people have to bill under certain things or whatever their constraints are, but they can still kind of like take a merit stance and incorporate a lot of these principles or elements into their work, and that can help with the burnout piece or just the connection, and might be something interesting to look at too.
Sarah, that sounds like a study we could do.
Sarah, I was going to share as well, Ilanit wasn't able to be on the call today because she had some other obligation, but she did recently do a study about doing merit on an inpatient unit and found really good results. So might be something helpful there as well in thinking about your work going forward. But I think what everyone's touching on at this point too is a nice segue to mention as well, like our next Merit Quarterly Conference will be on exactly this topic. So I think Alicia is going to talk about how she's adapted merit to work in the VA in a trauma clinic, and talking about like how she's, you know, in a clinic that's doing a lot of very manualized protocols, but has still found ways to like incorporate merit into that work, and is going to be kind of sharing her thoughts with us there. And that is on, hold on, I have it pulled up, December 4th, the same time at 10 o'clock. Do folks have any other thoughts or questions on this topic, or have we kind of reached like the conclusion of our meeting today? Well, if that's all for today, we'll go ahead and wrap there. Thanks so much to Laura and Courtney for presenting today, and we'll see everybody back in December.